Thank you. Okay, our talk tonight is going to be, as Dr. Eller just mentioned, on Bartonella and human diseases. Bartonella is a very interesting species and subspecies of bacteria. Hardly a week or two passes without some new species or subspecies being discovered and renamed. And more of them are actually becoming known to cause diseases in humans. So therefore, this talk. This is the outline of my talk. We will mention some history and taxonomy about the different Bartonella species, a few words on microbiology, and focus on the major disease processes that are caused by Bartonella, diagnosis and challenges associated with it. And finally, we'll spend some time on culture-negative endocarditis, which Bartonella is known to be an important cause, and a few words about therapeutic aspects. Bartonella is actually, although it's being talked about as emerging and re-emerging disease, it's been around for a long, long time, it looks like. Dental records from 4,000 years, and some people say longer, have shown that Bartonella henselae have been discovered, DNA records of them. And some relics of the Inca Empire depict the disease known as Verruga Peruana, which we know today is caused by Bartonella bacilliformis. So at least several thousand years old since they've been around. The history of Bartonella goes to, it would be a disservice, I think, if we don't mention these two gentlemen here. The one on your left, Daniel Carrion, was a medical student in Peru who was puzzled by this disease that suddenly happened in La Oroya, up in the mountains of Peru. And what has happened was a group of people were being moved up the mountain to build this railway between Lima and La Oroya, and a lot of these people were coming up with this very serious illness. In some reports, up to 4,000 of them died, actually, of this acute febrile hemolytic disease. And the ones who survived, some of them later on developed this warty-type skin eruptions. And of course, the curious Daniel took some of this warts and injected it into himself, and he developed Oroya fever, essentially. He actually meticulously documented the disease process and left, the natural progression of the illness, but unfortunately he died of the disease within a month. And later on, his countryman Alberto Barton discovers in the early 1900s, and the bacteria was renamed in his honor, Bartonella. So that's the history. As far as taxonomy goes, there are many species and subspecies of Bartonella. At last count, there are 43 species and subspecies. However, the three main ones that we are interested in that cause most of the human diseases that I labeled the three big ones are the Bartonella henselae, bacilliformis, and quintana. So those are the three that we will focus on. This is just a slide showing the diversity and complexity of these species. The three major ones are on top there. And they do go into type of diseases they cause, the hosts and the vectors that transmit the disease and where the disease harbors. This slide probably is a little older, but it ends at 38, but it's 43 at the moment. Until about 1993, or the early 1990s, only Bartonella bacilliformis, which is the main agent of Oroya fever, and Verruga Peruana was the only bacteria in the genus. However, during the early years of HIV, a type of disease was happening in these people, which was later on known to be caused by Bartonella. At that time, this bacteria was named, and you may see this in some of the older texts, as Rokia quintana. and I think it's named for a Brazilian microbiologist, Roca Lime. And subsequent studies of these bacteria actually showed that the bacilliformis species of Bartonella and what was initially known as Rockelemia actually were the same group, and everything was merged into the same genus of Bartonella, and everything that we know about them actually belongs to that genus now. As far as microbiology, I know microbiology is kind of important. Like judging from the in-service exam, it looks like people are interested in what type of bacteria these bugs are. So Bartonella is gram-negative, it's aerobic, fastidious, which means it grows in media with special nutrient requirement. You have to fortify the media for them to grow, which is one of the reasons why a lot of them actually don't grow, because if they are cultured in a regular media, and also they are capnophilic, meaning they do like CO2. So you would have to introduce CO2 into the media for them to grow. The oxygen tension needs to be lowered, CO2 tension needs to be higher. They also need to be grown in a heme environment, and you may see different names for this agars and growth requirements. People may use heart infusion agar, Colombia agar, Brucella agar, all of which are kind of interchangeable and similar in some way. They all contain a high content of heme, and that is one of the requirements, a major requirement, except the B. bacilliformis. Of course, there is always an exception to the rule, which grows without carbon dioxide. Some words about pathogenic mechanisms and features of these species. They are gram-negatives, as you know, with double membranes, and they have some very unique characteristics which kind of explains the type of diseases they cause. And one of them is their lipid polysaccharide is very less immunogenic to the human body anyway. Also, their outer proteins, which are depicted in green in the outer membrane here, known as VOMPs or VOMPs, or variable outer membrane proteins, not only they do not induce immune cells, they're actually known to suppress toll-like receptor 4, which is a very important component of initial antigen presentation, and that underlies how these bugs get entry and then avoid detection and stay intracellularly for such a long time. They also have a very special predilection for vascular endothelial precursor cells. They kind of attack the precursor cells from early on, and they cause proliferation of vascular endothelium, which also explains part of the reasons why they cause endocarditis, for example, because they have predilection for valvular endocardium endothelial cells. Not only they do stimulate growth, they also inhibit death. So they inhibit apoptosis, increase. So kind of important. This kind of reiterates the same, just only to show some of their virulence factors, which I suppose is kind of important for us to know as well. One of them is the pili or appendages, which helps this bacteria to attach to cells, and also a way of avoiding detection by the immune cells once they gain entry into the cells. And certain genes you may hear every now and then, a gene called BAD-A in association with Bartonella adhesin A, and that is known to be an adhesion factor involved in production of biofilms where these bacteria stay. And this slide is just kind of a repeat of what we have talked, focusing on the three major ones and a few others that cause human disease. And we will be coming back to it later. So now we go to the major disease processes that are consequences of Bartonella infections. So one of the main Bartonella species and subspecies is Bartonella henselae, which is the causative agent of cat scratch disease, bacillary angiomatosis, Pieliosis hepatis, endocarditis, specifically culture-negative endocarditis, a condition known as relapsing bacteremia, which manifests as a fever of unknown origin, and sometimes also vertebral osteo. Cat scratch disease, which is caused by Bartonella henselae, is transmitted by cats, but you don't need to have a scratch, however. You could actually get a lick or a bite from the cat. It is also reported, actually, a bite from a cat flea could potentially transmit the disease from the cat to the human, although a less well-known way of transmission. About a case per 10,000 occur in the U.S., so it's probably about a few hundred cases in Tampa Bay area potentially. So it's highly likely that we will see a cat scratch disease around here. The typical presentation is an inflammation as the porta of entry at the site of the scratch. But it could be so mild that it may not be noticed. Actually, a lot of people don't even know that they've been scratched or bitten by a cat. The most pronounced symptom would be enlargement of original lymph node, which usually happens in 1.5 to 2 weeks after the initial inoculation. Some people develop fevers and malaise and systemic symptoms, but those could be also very insidious. Sometimes it could be very transient and not noticed easily. And most cases actually do take a very benign course. A lot of people don't get sick very much. Most of the symptoms happen from an enlarged lymph node becoming tense and painful. However, some very serious complications are known to occur even from a cat scratch disease, including encephalitis, meningitis, osteomyelitis, and of course culture-negative endocarditis. As far as cats, and which of course the name attributed to them, they in some sero surveys, up to 70% of cats, even when they are born in a house, have been shown to harbor Bartonella henselae, and this has been confirmed across nations, across continents, and the cat flea, that picture of which you see over there, scientific name over there. I'm not trying to pronounce that, but anyway, that so you could potentially get it. So it's a cute little cat, not so benign as they are. As far as diagnosis, how do we diagnose cat scratch disease? A lot of the presentation is typical with the story fitting. Immunofluorescence assays and EIAs for IgG or IgM. However, absence of IgM does not exclude an acute or recent infection because IgM production is very brief in Bartonella. So you may actually miss it by the time they come. So if the story fits and there is an IgG, even though it means a past infection, you could actually take that as an evidence of acute infection. Cross-reactivity with Bartonella bacilliformis happens. Even in that case, if the story fits, that is taken into account for when the serology cutoffs are determined. You could culture the bacteria from the blood or from a lymph node aspirate. However, you have to pay attention to the culturing conditions. So you would have to tell the lab, is sarcopnophilic, I want heart infusion agar or heme added, and mostly we don't do, we just order cultures, and we could potentially miss it, and chances are we'll miss it. You could do histopathology, biopsy lymph node, and PCR it, and there used to be a skin test. FDA had actually not approved it, and it's not recommended anymore because the serology is believed to be more helpful for diagnosis. So as far as treatment for cat scratch disease, the majority of the cases actually take a benign course and you may not even need to treat them. A lymph node aspiration, if it becomes tense and painful, has been recommended. However, certain complications do require treatment, and that includes encephalitis and neuroretinitis, which could accompany a cat scratch disease. We will come to that later. And also people who have immune deficiency, either chemotherapy or HIV, also probably would need therapy. There's various reports of different antibiotics being effective. A lot of the reports come from France. For some reason, there's a big Bartonella study center there. Doxycycline is a very recurring antibiotic, but rifampicin, macrolides, including azithro and cipro, have been used. A lot of times when there is a serious illness, gentamicin has been added to the regimen with another agent. And most of the reports show that addition of gentamicin actually decreased the complication rates and improved outcomes. There was one recent case report in the New England Journal of Medicine where a patient who recently acquired a kitten and becomes with decreased visual acuity, and the only manifestation, the only hint was that he had stellate retinitis. That was the only thing that was found, and that person was treated with a 4-week course of doxy and rifampicin, and vision was restored. Speaking of vision, Bartonella, card scratch disease and Bartonella henselae as a complication or as part of the same disease process can infect or involve the eye. One of the most well-described syndrome is this thing called Parinauds. Parinaud is a microbiologist from France. Oculoglandular syndrome. The pathogenesis is not clear. One of the thinking is people may actually inoculate the bacteria from an infected skin lesion or a cat scratch disease into the eye, and they do develop this granulomatous conjunctivitis. And any and all parts of the eye could be involved, including uveitis and retinitis and neuritis, and optic nerve granulomas have been described. Here are some pictures to kind of which encompass the things that we discussed. These are cervical and preauricular lymphadenopathy from a cat scratch in a young child. That is axillary lymph nodes, which are tense and painful in a person that had skin lesions. And this is, to your right, granulomatous conjunctivitis. And this was a case from a New England Journal where a young person, 20-something-year-old, presents with visual acuity problem and found to have stellate retinitis. Supposedly this is very common presentation for Bartonella, although not necessarily very specific to it. The next disease, so that was about cat scratch disease and associated complications. So while we're still on Bartonella henselae, one of the 3 major Bartonella species is bacillary angiomatosis, which led to the discovery of the subsequent Bartonella genus. It is a proliferative disease of vascular endothelia or epithelia. People present with solitary or multiple papulonodular cutaneous lesions. They could involve mucous membranes. They could be solitary sometimes, and they could be hidden in places that you would normally see, like at the sole of the foot. Some of the lesions are not just cutaneous. They could be deep into the muscle and the fascia, and including into the bone. Classically, this one is associated with Bartonella henselae, but Bartonella quintana, which is one of the 3 species, could also cause bacillary angiomatosis. It was originally described in HIV patients in the early 90s, but subsequently shown to occur in people that have immune compromise for other reasons, other than HIV as well. The Bartonella henselae lesions could be described in a test, for example, or in various languages. So just pay attention: red and papule, flesh-colored or colorless papules, or hemangioma-like lesions. And the size could vary from very small and barely detectable to really big fungating masses. The nodules could be covered with scales and plaques. And sometimes they are described as large and pedunculated and polypoid and exophytic. So I just added all those words in there, so when you see them, you'll remember. Those are some of the various lesions of bacillary angiomatosis. which would encompass all of the things that we talked about. Some lesions could be solitary, and you may easily miss them if a person is covered in sole. They could be inside, actually, the upper roof of the mouth as a single lesion. They could be confused with either excoriation or cellulitis and periungual process. They could appear differently in a darker skinned person. Diagnosis of bacillary angiomatosis in a classic presentation is very clear and usually very clinical features. The lesions can be biopsied. You can do serology as well as PCR of the lesions. As far as histology and serology, it would also be, I think, important for us to remember this Wartin and Starry silver stain. Wartin and Starry are two microbiologists who came up with staining protocol, and the silver only talks about silver nitrate. In the stain, the bacteria have a tendency to aggregate, and they show as black. In the background will be stained yellow or red or gold. So I chose the two slides to show the different color schemes you could potentially be seeing, and if this could be presented in a diagram or a test, for example. So Wartin, Starry, silver. Treatment for bacillary angiomatosis, the theme will be the same: a tetracycline, a doxycycline, a macrolide, a quinolone, or an aminoglycoside if you suspect a serious illness. Some dermatologists do use cryotherapy on them with caution because they have a tendency to bleed. They are very highly vascular. If you remember the pathogenesis of these bugs, they do lead to hyperproduction of endothelial cells, and a lot of this have actually extra vasculature in them. Electrodesiccation and curettage has also been done for them if you have a single lesion on a less serious place. The other disease process, while still we are on Bartonella henselae, is Peliosis hepatis, which Pelios comes from the Greek for blue or discolored or purple. These ones, most patients present with pain in the abdomen and hepatosplenomegaly or isolated hepatomegaly. And it is characterized by having multiple blood-filled vascular hemorrhagic parenchymatous lesions in the liver. And the lesions could be very small or fairly big, could be up to 3 centimeter, golf ball size. Peliosis was originally described in association with tuberculosis. Actually, the original description of it was TB in the early 1900s, but subsequently it was shown that it could occur in a lot of other disease processes where immunity is compromised. But Bartonella henselae is a very common association with it, especially in association with HIV. Imaging could look like either metastatic or hemangiomatous lesions in the liver, multiple enhancing liver lesions. You could potentially have other lesions in the spleen or adjacent organs, and that is a gross pathology specimen of an autopsy on the right and a histology on the left, where the blood vessels essentially are filled with hemorrhage and venous dilatation. As far as treatment for Peliosis hepatis, it's not a lot of experience in the literature. Some people advocate treating the underlying problem. If it's HIV, controlling the HIV may actually be sufficient. If it is in the face of malignancy and chemotherapy or suppressive therapy, maybe modulating just like you would do with PTLD. The use of antibiotics is questionable. Some people have used it with variable success rates. Partial resection of the liver has been attempted in some cases, and in some instances it has even led to liver transplant. Then there are kind of relatively controversial areas of Bartonella henselae in autoimmunity. This one is not a clear-cut association, has not been established. However, there are cases of juvenile arthritis, you may even say juvenile rheumatoid arthritis, where the disease activity goes up and down with the rising and falling titers of Bartonella, and people have associated the two and considered perhaps it is an inciting agent for the arthritis. It may not necessarily be rheumatoid arthritis, although you could potentially have RA positivity. A rheumatoid factor could be positive in these people, but it could be a type of immune complex illness. There was also increased rates of seropositivity reported in various vasculitic diseases, including Henoch-Schönlein and leukocytoclastic vasculitis and Coombs-positive autoimmune hemolytic anemia. There has also been report of HLA-B27 positive people presenting with uveitis and having high titers for Bartonella, where these cases could very well be maybe just acute infections or chronic infections of Bartonella with subacute inflammations in the eye. But that's something out there and perhaps an area for future investigation. So that was Bartonella henselae and 3 or 4 major diseases we talked about, which would be the cat scratch disease and associated illnesses, oculoglandular syndrome, pileosis hepatis, potential autoimmunity associated with it. Bartonella quintana, which is the other one of the 3 major Bartonella species, is the cause of trench fever. And classically, this happened during the First World War, where people were living in very tight corners and unsanitary conditions, and they developed body lice, and the disease was transmitted from person to person through the pedunculus humanus. However, there was a recent re-emergence of this disease dubbed as urban trench fever. A lot of the people who live in similar conditions like the First World War, homeless people living in shelters, sometimes living under the bridge, but a lot of them together, have been coming with this acute febrile illness. And people actually have done surveys, and like a survey from Seattle showed up to 20% of those people were seropositive for B. quintana. And it's characterized, trench fever is characterized by a sudden onset of acute fever, myalgia and retroorbital pains, as well as bone pains. For some odd reason, shin pain is classically associated with it. I don't think anybody knows why exactly the pain is pretibial. The fever could take a 5-day relapsing fever, and that's why the name quintana, from the Latin for 5, came. It could, however, take a chronic course, and people could present with fevers of unknown origin or culture-negative endocarditis. As far as diagnosis for trench fever or urban trench fever or Bartonella quintana, blood cultures, again paying attention to the culturing conditions. Serology with immunofluorescence and IgM and IgG. Serologies, again paying attention, the lack of IgM doesn't necessarily preclude acute infection in this case. Biopsies and histologies, and with the Wartin and Starry. As far as treatment, again, this is a recurring theme, and I guess if we remember doxy, we probably will be okay when it comes to Bartonella. But in macrolide, and for people who have a serious illness, addition of an aminoglycoside has been advocated with good success. The other one of the 3 major Bartonella species is Bartonella bacilliformis. This is the original disease that has caused Oroya fever and Carrion's disease in Peru. That is a disease that Daniel Carrion actually took a specimen out and injected himself with. It is transmitted by the sandfly. This one is a kind of endemic zoonosis, if you would, because the bugs are fairly restricted in the geographic area of the high altitudes of Peru, and which explains why it happened initially. People were introduced to this area and were not immune to it, obviously, and they got sick, and a lot of them died. Sporadic cases, however, have been described in returning travelers, some even from the U.S. And also the area that the sandfly actually lives and breeds has been expanding to a lower altitude. It still happens in fairly high altitudes, but bigger areas. So it is possible that eventually we could find these bugs in areas that they're not there, and we could be faced with it. But for now, it is a disease that is restricted to the upper highlands of Peru, Ecuador, and Colombia, and only important for us in as far as returning travelers or fever in a returning traveler. The classic manifestation of Bartonella bacilliformis infection takes two forms. One is the classic Oroya fever, which is a very acute, high case fatality, febrile hemolytic anemia, which kills up to 80% of the people, actually, in up to 90% of the people in those when it occurs. And then there is an eruptive chronic form of the disease, which gave us relics from the Inca Empire, which is the Verruga Peruana. I got this from some charity which was actually traveling up in the Peru highlands, and they encountered this person, and in one of their newsletters they have written Verruga Peruana ravages a man in the Peruvian Amazon, and they had that picture. I thought that was interesting. So the disease Oroya fever can have incubation periods up to 60 days, so returning travelers, if you encounter, may not necessarily be within the short periods that we usually are accustomed. Humans are only known reservoirs other than the vector transmitting from person to person through a vector. It is one of the few bacteria where in some cases it infects almost every red blood cell in the human, which explains the high case fatality rates of up to 90%. And the Verruga, if people who survive or people who have subclinical illness and do not develop Oroya fever may develop Verruga Peruana, which is a skin eruptive form of the disease, loosely similar to Bartonella or bacillary angiomatosis, but a different disease process caused by a different subspecies of Bartonella. And then a few words about blood culture negative endocarditis. The definition, the operational definition for culture negative endocarditis is 3 sets of blood cultures are negative after 5 days of incubation. There's variable incidence of culture negative endocarditis. In some reports, only up to 2 to 3%. In some countries and some regions, up to 30% of endocarditis cases being culture negative. And there's probably several reasons why there is such wide variability. One is the availability of testing. You may not have all the immunofluorescence and PCR and Wartin-Starry to actually make a diagnosis, therefore it is negative. It could also be the antibiotic use patterns of different countries, because some people, like in developing world, like in Ethiopia, where I'm from, or some other places, people actually have taken some antibiotics already. When they come, they could buy it on their own. So that's probably explains. But the current thinking is probably it accounts for about 3 to 5% of culture negative endocarditis, Bartonella. So still a very important cause of culture negative endocarditis, despite the regional variability and the wide 3 to 30% range description. Some of the other reasons why culture may be negative, of course, pre-treatment. We said right-sided endocarditis may not be as bacteremic into the systemic circulation because pumps into the lung, and having a cardiac implantable device and having a fastidious organism which has a special nutrition requirement for growth, therefore it will not grow on them. As far as the epidemiology of culture-negative endocarditis, there's a worldwide geographic distribution, more in the developing world than in the developed world, not surprisingly. There's a fairly high male-to-female preponderance, and the reason is not clearly known why more male will have Bartonella endocarditis, which is culture-negative. It could explain the underlying demographic differences between men and women being more likely to be homeless or alcoholics or living in crowded conditions rather than independently associated genetic factor with the gender. Most of the people that have Bartonella-related culture-negative endocarditis tend to be younger than the other endocarditis cases. Again, it might also, the underlying reason could be the underlying demographic situation. Bartonella quintana is associated more frequently with homelessness and alcoholism and lower socioeconomic status. Again, not surprising, body lice. And whereas henselae associated more with having an exposure to cats, so kind of an important ID question. Do you have a cat? Type question. It is also, the Bartonella henselae was also, has been described in association with other endocarditis, such as staphylococcal endocarditis. And the theory was because B. henselae has all this VEGF and angiogenesis, it might prime the valve in the endocardium for infection by other bacteria. Therefore, even when you see a culture positive for staph, for example, if the story fits, there may still be an underlying Bartonella disease there. At least in some reports that has been mentioned, and I'm not sure if that is exactly clear. Quintana accounts for 3/4 of the culture-negative endocarditis associated with Bartonella, and the remaining 25% to henselae. And the vector, again, is Pediculus humanus, or the human body lice. A few words about same kind of pathogenesis features that we talked about, reduced lipopolysaccharides, having a variable outer membrane proteins, and also the angiogenesis and priming of the endocardium for infection by other bacteria. Not only that, also Bartonella quintana specifically is endowed with this ability to pierce the red blood cell, and that's the micrograph, the scanning electron micrographs that you see up there, where it actually goes into the red cell without bursting it open somehow. It forms a vacuole and is pinched in, because typically the red cells would burst and the bacteria will be all over the place and it will be detected. So that's kind of an interesting mechanism. And this persistent intraerythrocytic bacteremia, not necessarily in the blood free, but inside the red cells, is a major feature of all of these Bartonella species. Henselae endocarditis accounts for the remaining 1/4 of cases. It tends to be very aggressive, and a majority of them end up getting valve replacement surgeries. A lot of them have a history of contact with cats, some sort of contact, not necessarily a scratch or a bite. And there are a few other species which have been associated with endocarditis, but probably not as important as the 3 main ones. The majority of the people who have culture-negative endocarditis from these bacteria have similar symptoms as other endocarditis, which are non-specific, insidious fever, weight loss, fatigue type symptoms. In one series of about 350 patients from France, the majority had symptoms of heart failure, such as exertional dyspnea on presentation. Half of them had weight loss, and the majority had a murmur, and typically it involves the aortic valve, so that's kind of important as well. As far as lab abnormalities, similar to other endocarditis, anemias and elevated ESRs. And as far as mortality, probably closer to the lower number now with advancing technology. There has also been, recently there was a movement to add the Bartonella serology as one of the Duke criteria's major diagnostic criteria. Just like Coxiella burnetii has been added to that criteria. In some of the newer Duke's criteria, actually, a titer of 1 to 800 or more for Coxiella is considered a major criteria. And there is a big move, and it's highly likely that that would happen as well, because the majority of this negative culture-negative endocarditis end up having Bartonella serology. So the only reason for this slide is to show you that highlighted text in there. As far as treatment for these Bartonella-induced culture-negative endocarditis, original studies in the earlier years of the early 90s have shown broad susceptibility. However, experience had shown that a lot of these people actually are not easily treated, or they're not easily treatable. Current guidelines advocate the same kind of like we said before, addition of aminoglycoside, at least for the first 2 weeks, treat a native valve for 4, and a prosthetic valve endocarditis with Bartonella for 6 weeks. The longer aminoglycoside has been associated with better mortality outcomes, as well as morbidity outcomes of sparing the valve from a valve replacement surgery. And those are your references. And thank you.